Okay, great. A local physician has been very active in medicine and politics, I would say, for many, many years, and is very knowledgeable about Medicare for All. I'm delighted to be able to, introduce you and have you address our meeting, Sam. So just briefly, Sam will do some introductory remarks of about 10 minutes or so, and then he's really here to answer any questions you have about Medicare for All. So,
thank you, Peter. This is a very cosmopolitan crowd we have here. By the way, Peter, in high school, I got creamed many times in Go, and decided I was better cut out for poker than I was for Go. What I hope to do is give you about, as Peter said, about 10 to 15 minutes introduction to the concept of Medicare for All, and then let you drive the conversation. I am a retired anesthesiologist. I promise not to put you to sleep. I would like, if you wouldn't mind, somebody to ask some smart-ass questions, because it really livens things up to get these strange questions that I've never heard before. Healthcare reform is the second leading cause of bar fights in America today. Used to be women were number one. Looks like politics has edged it out. What makes it so controversial is its complexity. Even our president will tell you that this is complex. 1 out of every $6 that we spend this year is going to flow through the healthcare industry. It also doesn't behave the way we expect standard businesses to work. As the costs of healthcare go up, the need for healthcare doesn't change. And finally, it's a sort of Damocles hanging over all of our families. Very few people here are confident that our families could survive a major hospitalization. It also hits businesses hard too, because we're the only country in the world that has labor management disputes over healthcare benefits, because we're the only country in the world where we expect our employer to pick our benefits and our insurance company and our physicians. I'm going to arrange things that probably many of you already know, but hopefully in a way that will have Medicare for All make sense. First, why do we need healthcare reform at all? When the Affordable Care Act was first rolled out, there were dozens of Congress people and governors who said, we have the best healthcare system in the world. It's hard to defend that. First, we spend per person and, excuse me, for GDP, twice as much as the average industrialized country. We are the most expensive country in the galaxy, as far as we know. If we were twice as healthy and paying twice as much, that would be acceptable. If we were just as healthy and paying twice as much, that might be tolerable, but we're not. On most measures of public health or medical outcomes, the United States ranks at or near the bottom of the industrialized world. Simple things like a diabetic in the US is more than twice as likely as a diabetic in Europe to have a foot amputation because they couldn't get treatment and a diabetic foot ulcer became necrotic, and so on. Thirdly, we are the only country in the world that endures medical bankruptcies. There's no other industrialized country where one of us will lose our home paying for treatment for a treatable disease. So we cost too much, our outcomes are terrible, and it's the most common cause of bankruptcy in the US, medical debt. The second questions trickier than it might sound. What are we trying to achieve? Are we trying to get the government out of healthcare? Are we trying to get the government into healthcare? Trying to get the profit out of healthcare, get the profit into healthcare? Is this a social obligation? Is it a personal responsibility? Do we want economic justice? We got to slow that down, and we're all right now going to put on our cap that says head of family. What does the ideal healthcare system look like to us taking care of our family? One, we want access. When I think about this, no matter how hired, fired, retired, or expired I become, I want to know my family is going to get the healthcare they need at the time they need it. And it's going to be independent of their credit rating. Access. Second, cost. We pay for healthcare multiple ways. So a plan that reduces our taxes but makes our premiums go up, or reduces our premiums and make our out-of-pocket spending go up, or out-of-pocket spending go down, and our healthcare, our taxes go up, is just an expensive game of whack-a-mole. It's all my money. You can call it whatever you want, but that total cost has to go down. And lastly, I want better healthcare. I don't want to tell a family member who gets pregnant that there are 59 other countries where she and her baby have a better chance of surviving the pregnancy. Access, cost, quality. The bumper sticker for that is better care to more people for less money. If somebody's coming at you with a plan that does not provide better care to more people for less money, it's just rearranging the deck chairs on the Titanic. It is not reform. In healthcare, as in any other public policy, there are basically three approaches to how we solve this. One is to keep doing what we're doing and hope for a different result. There's a medical diagnosis for that condition. Unfortunately, the Affordable Care Act is an example of the same thing. It changed the rules, but it's still, in the United States, a zero-sum game. The only way one person can get more care for less money is someone else to get less care for more money. The second approach is to try things that might have worked with flat screen TVs and cell phones and see if it works in healthcare. All sorts of good ideas: consumer-driven healthcare, high-risk insurance pools, block grants. These are all great ideas, but they're ideas. There is no evidence, there's no data to say that this will work in healthcare. We could try these, but we're experimenting with a $4 trillion industry. The last approach is to look at systems that already provide better care to more people for less money and learn. Now that approach is easy, then it gets hard, then it gets easy again. It's easy because any other nation in the world where you can drink the water provides better care to more people for less money. The hard part is they're all different. Don't believe what you hear on talk radio. It's not all socialized medicine out there. As a matter of fact, no country uses socialized medicine except Cuba. But then it gets easy because all of these other industrialized nations have one characteristic in common that we don't. It's universal health care. Now, universal health care is more than a slogan. It really has three components, again, totally lacking the US. One is everybody's included, nobody's excluded. But of course, that means that nobody can be excluded, but nobody can opt out. Participation in a healthcare program is mandatory in every other industrialized country. By the way, it's also a lifetime commitment. We'll get back to that. The second component is everyone shares the same set of comprehensive healthcare benefits. Comprehensive does not mean unlimited. There's no place in the world where I can get unlimited care on somebody else's dollar. What comprehensive means that treatable conditions get a treatment. Anyone in these industrialized countries has the option to spend more money for more benefits or for more care, but nobody can spend less money for less care. And lastly, any patient can see any provider, and provider payment reflects the value of the service, not the value of the insurance. In insurance lingo, universal healthcare means a community risk pool, one risk pool, common benefits, one network. Every industrialized nation has nibbled away and compromised one of those at a political expediency, but it compromises their efficiency. We're the only nation that completely eliminates all three of them, and consequently, we have the most expensive, inefficient healthcare system ever created. Universal care plans have two basic ways of paying. One is multi-payer with multiple private health insurance companies. Central Europe and Japan use these. And the other is single payer. That is, everyone pays a tax and the government pays providers. In both cases, whether it's private insurance premiums or public funds that pay for care, the care is for the most part provided by private providers. There are rare exceptions. In some cases, not only does the government pay for health care, it also provides the health care. That is, when you go to the hospital or to a doctor, everyone you see has a government badge. There's no industrialized country that uses this on a national plan. By the way, that's what traditionally socialized medicine means. There's really only two examples of socialized medicine in the world. One is, as mentioned, Cuba. The other is the VA health program. So in a decision tree, this is summing up what you just heard, there are two kinds of healthcare systems in the industrialized world. One is universal care, and the other is chaos. We use chaos. Universal care has two ways of paying for it. One is with private providers, health insurance companies that all sell the same insurance plan with the same network. It's a multi-payer plan. And the other is paid for by the government through taxes, called a single payer plan. In the rare event that you have a single payer plan and all of the healthcare is provided by the government, that's called socialized medicine. I'm going to conclude with the concept of Medicare for all. As my colleague Ken Rosenberg has said, Medicare for all is a metaphor. It's not a reality. Medicare for all is shorthand in the United States for a national healthcare program funded by taxes with a single benefit program, a single network, and a single risk pool. It's hard to get all of that on a bumper sticker, So it's easier to say Medicare for all. Why is that metaphorical rather than real? American Medicare is the worst single payer system ever created. It's inefficient, it's complex, it's expensive, but it has two things going for it. One is it's a heck of a lot better than what our seniors would get if they didn't have Medicare. And that's bupkis. Translated, it's nada. Nobody wants to sell health insurance to seniors because they don't have a lot of money and they've got a lot of chronic diseases. The other advantage of Medicare is that it does a good job of turning healthcare dollars into healthcare. We talk about the administrative costs of private insurance. That averages in the US about 18%. The average for Medicare is less than 4%. When it comes to reducing the administrative losses in healthcare, Medicare is 4 times, 5 times as efficient as private health insurance. One more point about administrative costs. Better care to more people for less money, that doesn't compute. How do you bring in more people and give them more care and spend less money? As you just heard, when of the dollars that we give to insurance companies, they consume 18% to process these billions of claims. But it doesn't stop there. Once that money comes to providers like us, we spend an additional $12 trying to collect money from the insurance companies. The insurance companies, by the way, deny 30% of all first claims. That's not because they're evil, mean, and wicked, bad, and nasty. It's because it's good business to do that. The United States loses about 30% of its healthcare spending on administration. How does that compare to normal countries? Well, that's 3 times the average in industrialized countries, and it's more than twice as much as whoever is in second place. That is the efficiency of single payer. There's one form to fill out, one network, one benefit program. If we could cut our administrative costs in the United States by 15%, we'd still have the highest administrative costs in the world, but we would recover $600 billion that we could then turn into healthcare, which is more than enough to address the unmet healthcare needs in the US. This is how a national tax-funded single-payer healthcare system can provide better care to more people for less money, simply by slashing our massively high administrative costs. That's a lot to absorb in just a few minutes. So let's all take a breath, and I'd like you to be thinking about your questions. And yeah, raise your hand, Carrie, you're up. Be sure to unmute yourself.
Thanks. I have 2 questions. Let's see. The first one at the top of my head is administrative costs sound to me like somebody's job. And I think that's where a lot of the fear comes in the insurance industry is, will that person's job be lost? And that will save a lot of money, but then what is that person going to do for work is the other question. And then I had a question about the UK and Canada. I'm surprised I thought that the National Health Service was providing the care. But so you made a distinction. You said only Cuba has that full single payer and provides the care. So that was my question about UK.
I'll answer your first question first, and if I get lost, you can remind me of the second part of your question.
Okay.
Jobs, that seems to be the unit measure for any progress. Yes, if we reduce administration, there will be jobs lost. Now, there are a couple studies that have documented that, but let's remember that the jobs are being lost and more people are seeking healthcare, which means we need more providers of healthcare. There are jobs created in healthcare at the same time there are jobs lost in insurance. What's the balance? There aren't a lot of studies that look at it, but there will be approximately 1.5 to 3 times as many new jobs in healthcare as are lost in insurance. Now, these aren't just neurosurgeons. These are cafeteria workers in hospitals. These are nurses' aides. These are RNs. These are X-ray technicians. Now, if you're an insurance biller at a hospital and you're out of work, that's not going to be pleasant. On the other hand, almost every single payer plan that's been proposed has budgeted for retraining.
Mm-hmm. That's nice.
And you're also going into a job market where there's maybe twice as many jobs offered as there are people seeking them. But most importantly, while you're retraining and looking for work, you and your family have health care.
Right on. Yeah, the
Yeah.
analogy I would make is when we're trying to get rid of coal and oil industry and retrain them for solar and wind, you know, that there are
Yes.
more jobs there anyway.
The second part you had was,
How's that
yes,
work?
the National Health Service in England provides the majority of care, but not all of it. There are private practitioners in England, and most of the surprisingly primary care providers in England are private. There is no pure system in any nation. Even the nations that use multiple payers have a government-funded safety net program, their own version of Medicaid. And even the programs that have, the nations that have supposedly single payer, like Canadian provinces and the UK, have private providers as well that people can seek. There's no pure system anywhere. There's no ideal system anywhere, but there sure are a lot of better systems out there.
Thanks.
Is that Anne? Is that?
It is Anne.
Yes, Anne.
A single payer system, would Medicaid be folded into that then? So we wouldn't have these separate programs that exist now?
I'm sorry, Anne, I can barely hear you.
Oh, sorry.
You're muted now, Anne. There you go.
Okay, try bellowing, Anne.
Okay, I'll try bellowing. In a single payer system, would we still have the need to have Medicaid, or would the single payer system supersede all these different programs that we have now?
It's a good question. Ideally, if we passed a national single payer plan, it would include everyone.
Okay.
We wouldn't need a safety net program because everyone would be included. We wouldn't need a special system for veterans because they'd be included. We wouldn't need a special system healthcare payer for children. They'd be included, and so on. Who raised their hand? Yes, Bernie.
I have a number of questions. There's some elements of our system that are problematic that you didn't mention, probably a lot, but some that come to my mind are this whole notion of fee-for-service model. Doesn't that drive up the price quite a bit? And would that change under, I mean, then we have that, as I understand, under Medicare and Medicaid too, right? There are diagnostic codes, procedure codes, billing is against those codes. So there's an incentive to provide a lot of treatments, obviously, and bill for them. That seems to be part of what generates some of the cost. Another would be the level of compensation of the providers, which always causes resistance, not always from insurance billers, but also from physicians and surgeons and everybody else who's really prospering off of our system. Well-trained people doing wonderful jobs, but very well paid, which I think is less so in other countries. That would be another source of resistance, would it not? And historically, of course, the AMA was one of the main opponents of any move toward anything but a fee-for-service private model of any kind. There are a few other elements. I don't know if you want me to continue listing or.
Because my memory isn't what it was, let me handle those two, and then we can go back. And let me take the easy one. There's nothing about a single payer program in the US that requires shafting providers. Single payer does not save money by withholding payment or cutting payment to physicians or to nurses or to anyone else. What single payer does is it averages all the payments. So in an article in Health Affairs, Dr. William Shao talked about the Vermont plan. The total amount paid to healthcare providers under the not implemented healthcare plan stayed the same. The average stayed the same. But of course, there are no average providers. So if we calculate it out, the payment under a single payer is less than what I as a provider would get with private health care. It would be more than what I would get with Medicare, much more than what I would get with Medicaid, and infinitely more than having my claim denied, not getting anything.
Would it still be based on treatment codes and so on, or would it be more of a capitation idea like our health maintenance organizations and so on?
There are two ends of the healthcare industry pipeline. There's how the money gets in at one end, then there's how the money comes out at the other. Single payer is a variation on how do we get the money into the system?
Right.
And it unifies it. Says all the money going into the system is paid for by taxes. How it comes out the other side, you have identified there's still a whole lot of complexity there. Single payer does not require global budgets, capitated funds, fee for service. Those are all variable. I believe it's important to realize when we're talking about single payer, we're not talking about switching all physicians to fee for service or making all physicians salaried. That is an option that's at our discretion. We don't need to do that to save money because so much of the money that's pouring in now gets diverted from administration, which is a leak in the pipeline, that more money goes out to providers to provide more care. One sidelight is American physicians earn more in sheer numbers or as a multiple of the median income than any other country in the world. And even in Canada. That was true before Canada went single payer. The fact that American physicians earn more money than anywhere else has to do with an American tradition that predates any of these payment systems. It is not necessary for American physicians to, for the average physician to give up income in order to participate in a single payer plan. But you can guess what a physician's going to think about a single payer plan if you know what their payer mix is right now. If I'm a highly paid medical specialist who only takes private insurance, as the payment regresses to the mean, I lose money. If I'm a primary care physician and most of my patients are government pay or self-pay, single payer system means I earn more. The average stays the same, but every physician has to do their own calculus, especially those who are in the opposite corners. Highly paid medical specialists like me, but who does mostly government, or a highly paid medical specialist, or a primary care physician who just takes private care. All physicians are going to be stroking their chin and thinking, what do I get out of this? Some of us will say, I'll sacrifice a little income to reduce my cost of doing business and to make sure my family gets access to healthcare no matter what happens to me, even if I don't wake up tomorrow or I stop being a highly paid medical specialist. And my friends in my community all have access to healthcare. And there'll be a few of us who will say, yeah, I'd rather have the money. Physicians are no different than anybody else. Ken, you've got your hand up. Bernie, we can come back to you.
Sure.
So I'm actually going to lay out a thought that I had as the discussion was going on, the kind of response to several of the questions that were being tossed around. Medicare for All is a specific piece of legislation that's been introduced into Congress. The sponsor in the Senate is Bernie Sanders. The sponsor in the House of Representatives is Pramila Jayapal from Washington. It proposes a bunch of changes that are all consistent with what Sam is saying. In one way of looking at the entire process is that it proposes to partially renationalize the healthcare industry. Doesn't take all the private out, but it takes big chunks of it out. And to place governance of the healthcare system into the hands of the government, in contrast to where it is now, which is in the hands of private industry. So health insurance industry, pharmaceutical industry, doctors, hospitals, they're basically making backdoor deals and lobbying the hell out of the process so that the public has very little input into the shape of our healthcare system. If the Sanders bill were to pass sometime in the next 5 years, 2 years, who knows, it would simply introduce a change in how payment is made. So the bulk of payment would no longer be from people to insurance companies to providers. It would be from the government to providers. And the governance would then be public. And if the public didn't like the way healthcare was being delivered, it would go through its elected representatives to change things, which is in fact what happened in England when people got upset that the government wasn't providing enough money to allow for shorter waiting times to see doctors and to get services. And I guess it was under Blair, basically Parliament said, we're getting all this pressure from our constituents. We need to change this in the following ways. And it passed relatively uncontroversially. So, I mean, in effect, Sam's talking about a lot of the details of what is Medicare for All, but we have to think of it as a dynamic process that we're essentially taking this large industry and putting it under public control.
Thank you, Ken. There's even more colorful ways to illustrate what Ken was talking about. Sometimes you hear people say, I don't want a government bureaucrat determining my benefits. Well, the option is, do you want a private insurance administrator determining your benefits, someone who is legally beholden to the interest of the insurance company? Remember, these CEOs of private insurance, if any one of them were to put the medical interests of their patients above the financial interests of the owners, at the very least, they'd be fired. But at worst, they would be charged with the felony of violating their fiduciary financial responsibility to the owners.
Mm-hmm.
Not only that, if you appeal to your insurance company, they won't even tell you what your benefits are. That's proprietary information. They won't tell you how much your physician is being paid. That's private. Now, that private insurance bureaucrat has a lot of motivation to take care of the owners, whether they're for-profit or not. That government bureaucrat has to do it out in the open. And if you don't like what's going on, you can put your legislators or your congressperson's fingers in a toaster and get something done. We hear a lot about waiting times in Canada. First, the United States has the longest wait times of any nation, industrialized nation. We have 40,000 people a year who die waiting for treatment for a treatable disease because they never get the money. There's no longer wait period than the rest of your life. But we hear about Canadian wait times. That's not because of single payer. Canadian wait times are long because their taxpayers are even more tight-fisted than the ones here. The Canadians could get rid of all of their wait times if they increased their healthcare spending by 10%, and they'd still be paying 65% of what we pay in the US without wait lines. But every time this comes up in Canada, the taxpayers say, you know, I'd sooner have the wait times than have a tax increase. Now, some taxpayers may think differently, but as Ken points out, that decision is a public decision. It's not hidden away behind locked doors, legally protected from investigation. Healthcare becomes a public discussion. Harry, you're up again.
Thank you. I just had an idea when we were talking earlier. I guess Bernie was asking about, but you know, what are the doctors going to be getting? And they're used to getting quite a bit, but they're also used to investing an extreme amount of money in undergrad and med school, etc. And they work very hard for this. And so I want to add on to Medicare for All, free college, free medical school training. And then we wouldn't have that, you know, backlog of that money that they must earn high dollar to be able to pay back those high loans. That's my solution to that problem.
You're right, Carrie. There are two financial pressures on American physicians that, for the most part, aren't felt anywhere else. One is the cost of medical education. The United States could pay for every medical student's tuition and their living expenses and the cost of hospitals and clinics to educate them for about $10 billion. Now, that's not chump change, but that is 0.08 of our healthcare spending. We could easily skim off a tiny sliver of what we pay and make medical education free. Every medical student would graduate without debt. Every hospital would be happy to train them. The other aspect is medical malpractice. As a Turns out the figure is similar. Annually in the US, all of the medical malpractice premiums total about 11 or 12 billion dollars. That is much higher, of course, than in other countries. In addition, the amount of defensive medicine is about an additional $40 billion. That is care that I, as an anesthesiologist, provide not to improve my patient's medical outcome, but my legal outcome. It's about $50 billion. Well, you can do the math again. That's not a lot of money. That is not what's driving up the cost of American healthcare. Both of these, that is government-paid medical education and doing something else with our medical malpractice system, can be done independently of single payer. And you're right, single payer will not address either one of those. Single payer does not solve all problems. It simply provides better care to more people for less money and enables us to address all the other problems we have. That you mentioned medical education, Bernie mentioned inequities in how physicians are paid, plus how much we overpay for drugs, plus the cost of multiple electronic medical records that don't want to talk to each other, plus the churn every year as people go from one insurance company to another. There's still problems. Oh, not to mention the inequities on race. Single payer does not end racism in medicine, but it does address one aspect of it. Everybody has access, whether you're on the reservation, whether you're in North Portland, whether you're in rural Oregon, regardless of your skin color, regardless of what your primary language is, whether who your employer is, how much you make, if you are employed. In a universal care system, in single payer, doesn't matter who you are. You can go anywhere, you'll get care, and your providers will get paid no matter who you are.
Mm-hmm.
We probably got time for one more. Michael, you got a question?
Yes, you didn't emphasize much about drug prices. And my concern has always been that there needs to be some measure of profit in order to continue to drive and incentivize the conversion of basic science into a commercial product that can be distributed to the population. Somewhere between the laboratory and the patient, there has to be a method, which has come to be our pharmaceutical industry. They're the ones really, right, that take it from the laboratory and distribute it to the population. So how do you reduce the cost without depriving, without losing that incentive to invest in the development and the distribution of new medicine?
In the good old days where women were women and ships were made of wood, most of the medical research in the United States was funded by government, the NIH. Now, only a small fraction is, but it doesn't have to be that way. If we went to a single payer system, we wouldn't have to take a big chunk out of what we save in administrative savings, and we could make the NIH 2 to 3 times as big as it is now. Keep in mind that most of the medical research that's doing now in private insurance is based on basic research done at the NIH. The drugs that are being developed in private industry, 90% of them are no safer or no more effective than any drugs we have now. 90% of what American pharmaceutical companies invest in are new drugs to patent, not improvements. The breakthrough drugs that we think about, these are based on research done with public funding. And we could, with a single payer system, make public funding very robust. Not to mention the other issues that you alluded to, like negotiating drug prices, which, as you know, Medicare is forbidden for doing. I could go on, but I think we have time for one more question. This is the 1 hour is the attention span of the average physician at grand rounds. And I don't expect anybody to stay longer than that. Briggy, it looks like you got a question.
I just typed into the chat. I'm just curious if there is room for alternative medicine in a system like this.
We can cover as little or as much medicine as we choose in single payer. We're already spending money on alternative medicine, but it's usually paid individually. The more different kinds of healthcare we incorporate into single payer, alternative, mental health care, dental health care, vision, hearing, transgender care, the more we include that we're already spending money on, the greater the efficiency of our system. So it's kind of a Weasley answer, but with a single payer system, the bigger it is, the greater the per capita efficiency. So we should, even though we can choose not to, we should include alternative medicine.
So let me make a comment to Griggy. The Oregon Health Plan, the Oregon Medicaid program, is kind of an example of where public political discussion, debate, pressure have affected the question of alternative medicine in being covered by OHP. Naturopaths are covered. They are unhappy with how much they're paid, but by and large, they're covered. A variety of alternative treatments are covered, but by and large, the criterion for coverage is the quality of the research supporting the effectiveness of particular treatments. And for alternative medicines, there's not a lot of research on that. So the answer is, yeah, it's possible, and there's no reason why it won't happen, but the criteria determine a lot of what gets covered and what doesn't.
Thank you. We're at the 1 hour point. I am happy to stick around and answer some of the intriguing questions on chat or others, but you all can be forgiven if you want to resume your normal life. Nobody will be offended. I thank you very much for participating. Bernie,
Thank you very
asked.
Yeah. Thank you so much.
Thank you
You're
very
welcome.
much. It's very
Thank you, Peter.
interesting. Great answers. Great opportunity to ask questions.
Bye.
Bye, everybody. Thanks,
Bye,
Peter.
thanks.
Thank you very much. Bye.
Bernie, you asked about long-term care. That fits into the same concept as alternative medicine, mental health care. We're already paying for this. If we fold it into a single payer system, long-term care becomes more efficient. There is a temptation when anybody wants to reduce healthcare costs to simply redefine healthcare so it doesn't include something, and then our healthcare costs go down. But we know that it doesn't. If we look at the sum of long-term care and conventional care that we're spending now, and then project it into what would happen with a single payer, our costs would still go down. Copays. I get worked up over copays. Copays are designed to discourage people who might need healthcare from seeking healthcare.
Mhm.
It punishes people who are sick by making them pay more when they do get sick. There is a belief, not substantiated, that copays pay for themselves in collecting more money. That's not correct because it costs money to collect copays. If you think about a $10 copay in your doctor's office, it costs more than $10 in service and labor to collect it.
Mhm.
Second, the idea is that copays will make people think twice about healthcare and will have a more efficient healthcare system.
It just makes them sicker.
We don't see that. Now, you do hear primary care physicians in universal care nations, Japan, Germany, say, half the people who come to see me aren't sick. And in fact, what we know is that in every other nation, people see their physicians 1.5 to 4 times as frequently as we do here. Yet they're paying half as much and they're getting better results. What's happening? Well, in summary, rather than have a patient try to figure out whether he needs health care before he sees a physician, the physician figures out if the patient needs health care after she sees the patient. The physician sees a lot of patients who don't need care, but there are a lot of patients who get caught early and they don't end up needing intensive care, tertiary care, urgent care, emergent care. The money says, get as many people as early as possible into the healthcare system. And I'll give you one last clever statement. The most expensive patients in the United States who drive the cost of healthcare up for everyone, with the worst results, who make our outcomes at the bottom of the industrialized world, are the patients who don't get care until it's too late.
Yep.
That's how we reduce costs and save money by getting patients into our healthcare systems as early as possible, not as late as possible.
Yeah.
Do lifestyle issues become part of that, those efforts? I mean, I think a lot of the costs are from preventable conditions. If people ate right and got proper physical exercise and so on, if you compare to some other countries where they have much healthier lifestyles and diets and so on, is that part of the model that you see moving toward?
There are 2 aspects to this intriguing question. One is Americans are more obese than any other industrialized country. On the other hand, our alcohol consumption is about average, and the United States has the lowest adult smoking rate of any industrialized nation. Now, thanks to vaping, that's going to change, but we can't blame our healthcare costs, our excessive healthcare costs, exclusively on bad lifestyles. There's another aspect to it, which is, personally, I don't think we should use healthcare for social engineering. I don't think we should punish people who make bad choices by withholding healthcare or making healthcare more expensive for them. There are ways to encourage healthier behavior. Most of them are taxes, not healthcare modifications. We know every state that raises taxes on cigarettes sees a decrease in the number of adolescents who start smoking. We know that municipalities that impose a sugar tax have citizens who consume less sugar. We know that if you raise alcohol taxes, people consume less alcohol. As much as taxes are a hard sell, if we are really intent on modifying people's behavior, I don't think we should use healthcare. I think we've covered more than enough. And for those of you who have stuck it out, thank you very much for attending. Peter knows where I live and how to get a hold of me. So if you would like to continue this conversation offline or create your own living room event like Peter's done, I'm available. I do weddings, bar mitzvahs, confirmations, living room parties. Happy to do it. Peter, thank you for making this happen. It's really
Thank-
great.
Thank you very much.
Thank you, Sam.
Very much.